My name is Anthony Rivas. I'm a professor of medicine at UCLA in Los Angeles. There's two manuscripts in the New England Journal describing the benefits of combining a BRAF and a MEK inhibitor compared to the what's now the old standard with the BRAF inhibitor alone. So the concept of combining a BRAF and a MEK inhibitor had been previously tested in phase 1 trials, which looked very promising, and then in phase 2 randomized trials. But obviously the data from that was not conclusive. Now we have actually three phase 3 trials that have been read out and reported as positive. Two of them with the combination of the dabrafenib and trametinib, one of them against bemurafenib, which was published just last week as a pre-release in the New England, and another one with the dabrafenib, which now it's published in the full in the paper journal, and then the combination of bemurafenib and the MEK inhibitor cobimetinib against bemurafenib alone, also published in the New England. Out of the three trials, one of the trials, which it was called the Combi-D because it was dabrafenib trametinib versus dabrafenib, had a benefit that was less than expected in terms of median progression-free survival. The median is what happens to patient number 50 out of 100. And sometimes, just by luck, that gets very close in the two arms. The overall curve, it's very clear that it's better to be on the combination than single agent. If we look at the combination from bemurafenib and cobimetinib versus bemurafenib alone, the median progression-free survival is much separated. It's around 3 months. And also the hazard ratio of the curves is highly positive. Then we have the most recent trial that's just reported as IMPRESS in the New England with Caroline Robert as the first author. There we see that the combination of dabrafenib and trametinib is better than bemurafenib, both in the hazard ratio of progression-free survival and in the median, telling us that probably the first study is just a matter of fluctuations of the curves. What the third study tells us conclusively is that the overall survival is better with a combination than with single agent. So overall, I would say that the new standard has to be to give a BRAF and a MEK inhibitor to patients. And I cannot foresee a situation where it would be preferable to give a BRAF inhibitor alone. What we're seeing with these studies are mostly weighted on the patients that have events within the first 1 year. And those tend to be the patients who had the most aggressive melanomas that are treated. They respond better with the combination than with single agent. But with time, we're seeing that the curves continue to go down. We know that there's resistance to the combination of the BRAF and MEK inhibitors, and the evidence so far from the laboratory suggesting that it's an amplification of the same resistance mechanisms that appeared with BRAF inhibitors alone. But what we don't know is what's going to be the long-term follow-up of these patients. We do know that with single-agent BRAF inhibitors, even though we all say that the benefit is temporary and it just lasts for months, there's some patients that are going on for 5 years since the phase 1 trials of bemurafenib alone. And I'm following a couple of those patients. With the combination of BRAF and MEK inhibitors, we're shifting the curves up towards an improvement in progression-free survival and overall survival. So it is possible that there may be a tail of the curve and a significant number of patients will have durable responses. Obviously, we don't know that. We're following patients from the phase 1 trials that are around 3-4 years now, and some of them are continuing to respond. A minority, but a significant minority. And we'll have to see with these larger studies if there's long-term benefit. So what we're seeing with these studies is that the benefit exists both with the dabrafenib trametinib or the GSK combination and the new combination bemurafenib plus cobimetinib, cobimetinib being a MEK inhibitor that's not yet FDA approved. It's this combination from Genentech Roche. It is a little bit of a flavor thing, and it may be like Coke versus Pepsi. The overall benefit is very similar. They just have some different flavors. The toxicities from the GSK combination is guided by the fevers, and the differential toxicities from the Roche genetic combination is from the photosensitivity. So maybe a patient who lives in Australia or in California may be better off with the GSK combination, and a patient who lives in Buffalo, New York may be better off with the Genentech combination. So the benefit of this combination is in tumors that have the BRAF mutation, and that's more common in melanoma, but also can happen in thyroid cancer, in a subset of breast cancers, subset of colon cancers. But it seems like the combinations for the other cancers, the non-melanomas, are going to be more of the BRAF inhibitor plus something that blocks receptor tyrosine kinase signaling through the PI3 kinase AKT pathway. The double hit in one pathway that we're seeing in melanoma by blocking BRAF and MEK, which are on the same pathway, one after the other, it may be something that's going to be restricted to melanoma. So overall, the results of these 3 clinical trials are very similar. They're all telling us that being on the combination of the BRAF and MEK inhibitor is better than being on single-agent BRAF inhibitor. The profile of benefit response in terms of responses and duration of responses is similar. But what differs a little bit is the toxicity profile. They're overall very well tolerated combinations. And the significant thing is that they're less toxic than the single agents, either BRAF or MEK inhibitors, mostly because the MEK inhibitor offsets the main side effect of a BRAF inhibitor, which is the development of squamous cell carcinomas, and these go way down when we combine them. But then there's the toxicities that are inherent to bemorafenib and dabrafenib. Bemorafenib can lead to photosensitivity by a mechanism that's not really known, but it's possibly because of the chemical structure of this drug, and it increases sensitivity to ultraviolet light, UVA light. And as opposed to dabrafenib, which by itself, and even more in combination, it induces pyrexia or fevers that can be quite limiting in some patients, in a minority, but a significant number of patients, where they can have fevers to 102, 104, and sometimes go with hypotension. Since the approval of the dabrafenib trametinib by the FDA around a year ago, we've had the chance to use it in the clinic without restrictions, and also continue to use in clinical trials. What I'm seeing is that patients on the combination do not have what I was used to seeing for the first 3 or 4 months of giving a BRAF inhibitor alone, which was that patients who would frequently complain to joint pains. They had this very limiting big articulation pains that would change around. It was rather frequent, and it's something that's hard to capture with the reporting of papers of these toxicities. That was something that bothered patients. And now we know that that has to be a toxicity from paradoxical MAP kinase activation, where the BRAF inhibitor is turning on this MAP kinase pathway in cells that are not BRAF mutant, which is the same mechanism that leads to the squamous cell carcinomas, the main secondary side effect from BRAF inhibitors alone. All of these side effects decrease by giving the combination of the BRAF and the MEK inhibitor.